My name's Joseph Ladapo. I'm an assistant professor at NYU in the Department of Population Health and also the Department of Medicine. Clinically, I work as a hospitalist at NYU Langone Medical Center. So I'll be talking about, as Alexandra mentioned, some of the challenges that we face as internists and hospitalists and primary care physicians in the evaluation of patients with suspected coronary heart disease. So primary care physicians, as you know, routinely manage patients with suspected heart disease. We routinely see patients that have symptoms that are concerning for potential heart disease. Might be something less concerning, but we have a strong need to try and rule out that dangerous diagnosis if left untreated. So here I have an estimate of about 4 million patients with stable symptoms that are suggestive of coronary disease. These numbers are a little bit different from Alexandra's because our units are, our level of analysis is different. So in the primary care setting, we typically blood work, EKGs, sometimes exercise treadmill tests. And often we refer patients who were not entirely able to convincingly rule out for coronary disease to a cardiologist. And some of these patients entirely bypass their primary care physicians and go directly to a cardiologist. The cardiologists typically will order stress testing with imaging. Sometimes they'll move directly to invasive testing to rule out or assess the risk of coronary disease. Repeated imaging is often an issue at this level, and we'll talk a little bit more about that. And finally, for patients who do undergo invasive coronary angiography, obstructive coronary disease is only found in about 60%. And what was interesting is in one of the slides that Alexandra showed, using a different patient population, the portion of patients who we can infer had actual anatomic coronary disease was actually about the same. So Alexandra had, I think, 12% of patients underwent cardiac catheterization at 1 year, and 4% of patients had a percutaneous coronary intervention or a CABG, so cardiac surgery. So the portion of patients who have obstructive coronary disease is really only about a third, and that's consistent in different patient populations. This population is also an expensive population by their sheer size and the types of tests that we order to evaluate them. So $4.5 billion annually at least in just direct medical costs. So what tests do we choose when we initially evaluate these patients? So this is what we do based on data from about 80,000 patients who are enrolled in United Healthcare. So this is the largest patient population that I've seen that reports these rates. So in this population, about 54% of patients initially undergo a stress MPI, so myocardial perfusion imaging or nuclear stress tests. 21% undergo a stress echo, and 25% undergo a treadmill stress test, no imaging. If we look at the Medicare population, the numbers are actually about the same. The distribution is very similar. The only difference is that in the Medicare population, instead of 21%, it's probably closer to 25% for stress echo, and closer to 20% for non-imaging stress tests, just an exercise treadmill test. So this is about what we do in the country. There's a lot of geographic variation in this, but this is about it. And we do it a lot. So utilization has grown tremendously in terms of how often physicians order stress testing to evaluate patients for coronary disease. So this publication here by Leslie Lucas is probably the it was the first major publication to document how really just amazingly unbelievable the growth in utilization of stress testing has been. So it basically grew among Medicare beneficiaries by almost 300% between 1993 and 2001. unbelievable. Nothing else is comparable to this degree of growth. And this is the red line. So the horizontal line is time. The vertical axis is the number of procedures per 1,000 Medicare beneficiaries. And the orange reddish line symbolizes stress testing with imaging, so nuclear stress testing or stress echo. The yellow line is non-imaging stress test, so just an exercise treadmill. So that fell modestly over the same interval, but just unbelievable growth. I hope my retirement account looks like that. So what about since then? So since then, Alexander showed this graph also. So this is Medicare data. This is unpublished data. This is from MedPAC. So since then, the purple line is, again, stress testing with imaging. So since then, it's continued to grow. Between 2000 and 2007, cardiac imaging grew by over 50% among Medicare beneficiaries. And it's slowed in recent years. But overall, there's been significant growth, clearly. This is driven almost entirely by nuclear stress testing. So another interesting phenomenon, almost a contagion. And Medicare spent $1.1 billion on nuclear stress testing in 2007 alone. When we consider both Medicare and private insurers, we're talking somewhere closer to $17 billion spent annually. So just a tremendous amount of resources that are going toward evaluating patients. So challenges to clinical care. There are many, and anytime I think when you have this many patients undergoing this many number of tests, you'll identify opportunities to really improve the care that they're receiving, and this is another example of that. So the first challenge, I think, is unnecessary testing. So unnecessary testing is a tricky thing to define. If every stress test that you do is positive and every patient has coronary disease, you're probably doing too few stress tests. And then what about on the other end? So just to put some bounds on it, this publication that I have here was just actually published a few weeks ago. I mean, it's been my sense that, and in an area of research interest for me, that we are actually lowering our threshold for evaluating patients and really entering an area where we're performing tests unnecessarily on patients that really don't meet clinical guideline indications for undergoing a stress test. I think all of us have had that experience where we felt not good about ordering a test on a patient, but we end up doing it anyway. So this publication by Rosansky was just published a few weeks ago, and he and his colleagues looked at patients who were evaluated at Cedars-Sinai. They have a very enviable database, clinical database of patients who undergo stress testing. And they looked at 39,000 patients, over 39,000 patients who underwent a nuclear stress test between 1991 and 2009. And what they found was absolutely remarkable. So the incidence of abnormal nuclear stress tests fell from 41% in 1991 to 9% in 2009. The incidence of ischemic scans fell from 30% to 5% over that same interval. So we're talking about 19 years, just a really dramatic decline in the yield of these tests. And of course, this far outpaces epidemiological changes in the prevalence of coronary artery disease, right? It's not even close. So clearly what is driving this is a lowering of the threshold for evaluating patients for coronary disease. This is one site, this is Cedars-Sinai, but it's almost certainly the case that this is happening all over the country. Another challenge that's related to the last one is unnecessary procedures. So Alexandra also highlighted this publication, really a landmark publication by Pam Douglas's group at Duke, that used data on almost 400,000 patients in the National Cardiovascular Data Registry, and sort of looked at the relationship between their initial diagnostic test, if there was one, and what was found at cardiac catheterization or coronary angiography. So here, again, only 1 in 3 patients were actually found to have obstructive coronary disease. So 2 in 3 patients received the cardiac catheterization unnecessarily. In other words, there was nothing that the cardiac catheterization got these patients beyond a definitive sort of diagnosis or absence of a diagnosis. And completely normal coronary arteries, so absolutely no coronary atherosclerosis at all, was found in almost 2 in 5 patients. So just to flesh this out a little bit further, looking at this figure here. So on the horizontal axis, we have the results of non-invasive tests. So this is not just stress tests, this is also EKGs. And on the vertical axis, we have the portion of patients who were actually found to have obstructive coronary disease. And then the three color bars represent different levels of risk in terms of the Framingham risk score. So I think there are 2 things that I take away from this. So one thing is that the portion of patients who have obstructive coronary disease, the fact that that's low, is primarily driven by these patients with low Framingham risk scores. So in other words, kind of low-risk patients who are getting cardiac catheterization unnecessarily. And then the other thing I take away is that it's interesting to see that the difference between positive and negative test results in terms of the distribution of obstructive coronary disease is pretty marginal. So that's also a very interesting thing in terms of the value of diagnostic testing. And then the third and final challenge that I think is really important in this patient population is unnecessary radiation. This is a very interesting phenomenon that we're only beginning to learn more about, and has only in recent years received the media attention that it almost certainly deserves. So, whether it's the New York Times, there are newspapers in this state that have also talked about the issue, New England Journal of Medicine, other journals that have started actually looking at what we're doing to patients in terms of the amount of radiation we're exposing them to. So part of the challenge with radiation exposure is that we just don't understand it very well. And in terms of what we know about radiation exposure, a lot of it comes from following patients, from following individuals who survived nuclear bombs in Japan. So nuclear stress testing accounts for 22% of the cumulative radiation from medical sources. So that's the first thing that's just remarkable. So this includes all sources of radiation that we expose patients to, including radiotherapy for cancer. And to put some scale into this and some context, one nuclear stress test is about equivalent to 1,000 chest X-rays in terms of the nuclear exposure a patient is exposed to. There is some range and flexibility in this estimate. Again, that is because we just don't understand sort of radiation and the impact that it has on our biology very well. That's equivalent to about 10 to 15 millisieverts. And to give you some additional context that I find really interesting. So people that are at risk for repeated radiation exposure, such as healthcare workers or people who work in nuclear plants, are typically restricted to 100 millisieverts over every 5 years, and a maximum of 50 millisieverts in 1 year. And one nuclear stress test is 10 to 15 millisieverts. So just very remarkable. So Andrew Einstein at Columbia published a paper that really brought a lot of attention to this in JAMA a few years ago that just looked at patients in Columbia that were followed for 8 to 10 years. And he looked at the number of patients who had repeat nuclear stress tests, and it was 40% of patients, 39% of patients. And the median cumulative effective dose of radiation that the patients had overall was 29 millisieverts. So really a substantial amount of radiation. And then even more when one considers other sources of radiation. In the Medicare population, this distribution is actually probably pretty similar. And then if we if we look at the U.S. non-elderly population, so this was another study published in New England Journal of Medicine of almost 1 million adults around the United States. Among these patients undergoing cardiac imaging, the mean cumulative dose of radiation was 16.4 millisieverts, and almost all of that was attributable to nuclear stress testing. So it's, we're just going around and performing a lot of nuclear stress tests. So, finally, I think the bigger picture, and at least the one that I think is sort of the basis for a lot of my own thinking, is how do we get from better testing, from testing to really better outcomes for patients? So this is just a nice depiction that I borrowed from Pam Douglas. It sort of shows the relationship, really. We start with a patient that we suspect of having coronary disease. We choose a test to use, hopefully an appropriate test, and we're talking about the different types of tests. And then there are technical issues, including image acquisition, how the radiologist interprets it, and then the outcomes piece. So the outcomes piece has to do with how we communicate with our patients, and ultimately what our patients do with these results and how we care for them.